Hello and welcome to this FERNE presentation. We will be discussing today seizure and status epilepticus patient guidelines, presenting a simple clinical pathway. My name is Edward Sloan. I'm an emergency physician in Chicago. This information was most recently presented at the 10th World Congress in Emergency Medicine in November of 2022. I'm Professor Emeritus at the Department of Emergency Medicine at the University of Illinois at Chicago in Chicago, Illinois, and I'm Medical Director for the Physician Assistant Studies Program at Dominican University in River Forest, Illinois. I serve as the Medical Director for New Rose Healthcare Management at Roseland Community Hospital, a safety net hospital in Chicago, Illinois. My thanks to the 10th World Congress and mi amigo Carlos Garcia Rosas. He is a great man and a force in emergency medicine. And thank you, all of you who are watching and participating in this educational endeavor. I have no financial conflicts. I serve as the FERNE President and Board Chair, FERNE, the Foundation for Education and Research in Neurological Emergencies, ferne.org. More about FERNE later. So in conclusion, when we are discussing the treatment of patients with seizures and status epilepticus in the emergency department, pre-hospital setting, or critical care areas of the hospital, we conclude the following. A new AES guideline was published 22 years later after the initial EFA status epilepticus guideline was published. The AES guideline, published in 2016, uses a three-phase approach to the treatment of seizures and status epilepticus. We know that the ACEP 2014 clinical policy does provide treatment strategies for relevant clinical questions, 4 questions were addressed, and guidelines and recommendations given based on the strength of evidence in the medical literature. We know that similar options for the treatment of status epilepticus are provided in the ACEP clinical policy and in the AES 2016 guideline. We know that information in the 2020 AES publication confirms that there is a great deal of uncertainty regarding the optimal status epilepticus therapy, but it does identify similar best options for consideration for patients with ongoing refractory status epilepticus. Recommendations. So from our analysis of guidelines and clinical policies that address the care of patients with seizures and status epilepticus, we have the following recommendations. It's important to know these guidelines: the 2016 AES guidelines, the 2014 ACEP clinical policy questions, and the 2020 refractory status epilepticus medication recommendations. It's important that the care that is provided to patients with seizures and status epilepticus be timed. That is, the minute a patient presents to the ED with convulsive status epilepticus, and or if a seizure begins in the hospital or other critical care areas, it's important to start the stopwatch and begin to follow how much time it takes, knowing that the stabilization phase and the 3 treatment phases optimally should all occur within the first 60 minutes of the onset of the seizure. We know that if guidelines and clinical policies are followed, it is possible to improve the outcomes of patients based on the use of a protocol. Because the second and third phases of treatment have no single supported preferred medication, we know then it's important to develop a protocol for your own individual emergency department or clinical care areas based on what medications are optimally utilized within your institution. In other words, the first phase that includes benzodiazepines, those benzodiazepines should be available in the clinical areas. Following that, it should be important to have at least one second therapy medication available, and one third phase medication available for the treatment of patients with ongoing seizures and status epilepticus. How do you make that selection? You select which agents could be used based on their optimal use within your institution and use them in rapid succession at optimal doses. That is to say, while one medication is being provided, another medication should be prepared so that it can be given immediately following the termination of the first initial anti-epileptic drug therapy. We know that because fosphenytoin, levetiracetam, and valproate are most likely to successfully treat status epilepticus, these medications should be the focus of subsequent use following the initial treatment phase with benzodiazepines. Thank you for taking the time to learn more about the treatment of patients with seizures and status epilepticus. For more information, please go to the FERNE.org website. And also, please subscribe to the @FERNE.org YouTube channel. We encourage you to go to all of our social media sites to obtain or to learn what are the most current optimal therapies for the treatment of patients with any neurological illnesses, injuries, and/or emergencies. FERNE.org. If you have any comments or questions, don't hesitate to email us at FERNE.org@gmail.com. I'd like to thank you. And Ken Moore, listed here on the left, also thanks you for your time and efforts on behalf of patients with emergency illnesses and injuries related to neurological diseases. Once again, Edward Sloan, thank you.